A pioneering genomic epidemiology study provides direct evidence that superspreading events profoundly influence local, national, and international spread of the virus and are a major contributor to the pandemic. Epidemiologists traced a variant of SARS-CoV-2 from a single individual in Europe to a conference in Boston which ended February 27, 2020. By mid-July, the epidemiologists traced that variant to one-third of all cases sequenced in Massachusetts and 3% of all genomes studied in the United States to date, including Virginia, North Carolina, and Texas, and to other countries, including Australia, Sweden, and Slovakia. Jacob Lemieux, MD, DPhil, is an infectious disease specialist at Massachusetts General Hospital and was part of a large collaboration among over 50 researchers from MGH, the Massachusetts Department of Public Health, the Broad Institute, Boston Healthcare for the Homeless, the Harvard T.H. Chan School of Public Health, and many others. Jacob, what was the downstream effect of this one individual at this conference? How many people or what geographic area ended up being affected by this one single individual?
It seems to be a substantial impact. Estimating the precise number of individuals is very challenging because what we don't have is a random sample from Massachusetts or a random sample from the United States, but several features of the data suggest that the correct order of magnitude here is that the impact of the event is measured in tens of thousands of individuals.
By August 1st, the Boston area had 92,885 infections and 6,542 deaths. COVID-19 is characterized by the prominence of superspreading events in which one individual infects an unusually large number of secondary cases. A superspreading event is the transmission of at least 8 secondary infections from a single source. A great deal of SARS-CoV-2 transmission has occurred in clusters of cases linked to events and gatherings, and those include cruise ships, churches, care homes, homeless shelters, and now colleges. Jacob, how often does this virus mutate, and how close does that allow you to get to actual individuals spreading the virus from one person to the next or to a group of people?
That's the critical detail, is our resolution is limited by the frequency that genetic diversity accumulates in the virus. We see one genetic marker emerge every 1 to 2 weeks in a given viral lineage. So that's pretty much the limit of our resolution. And it can be useful in several concrete ways. So one question is transmission happening in the institution in question or out in the community? If you have a school with an outbreak, are the viruses all related because the outbreak is spreading in the school? Or is the school the canary in the coal mine of rising level of community transmission and that you just haven't looked for or observed yet? And sequencing the viruses is the way to figure that out. It matters because if it's rising community transmission, shutting the school isn't going to help at all. But if it's an outbreak within the school, transmission that's happening in the school, if you change the infection control practices in the school, or in the most extreme case, if you close the school, then you can abort that transmission right then and there.
Genomic data can reveal connections between cases that cannot be detected through conventional epidemiology alone, including direct evidence of superspreading based on shared viral sequences. The presence of a temporal signal means that a molecular clock can be fitted to infer the timing of ancestral branching based on the SARS-CoV-2 genomes, allowing epidemiologists to trace the history of an infection backwards in time to its origins, in this case from China to Europe, France, and Boston. As the virus transmits from person to person, it accumulates more and more mutations. These come from mistakes that polymerases make in copying the virus, and have so far occurred in regions of the virus that have no effect on its pathogenicity or biology. These mistakes or mutations are identified as SNPs, In Boston, the novel SNP C2416T was sequenced. The RNA polymerases of RNA viruses, like SARS-CoV-2, are termed the king of errors, causing a mutation once for every 1,000 to 100,000 nucleotides polymerized and leaving a telltale stream of mistakes or mutations behind them as clues as to where they have been. Jacob, is this virus a little like a passport in that you may have picked up a SNP in France and one at a conference and one in Worcester so that it has a number and you are actually able to look at it and go, well, it sort of came from here?
I think that's a good analogy. It's yeah, it's like getting a stamp in your passport, but the stamps are not 100% linked to the place and time at which they're given. So there's an inferential process by which we say it appears that nearly all of the viruses that have this particular marker were in Western Europe at this particular time. Therefore, given that information, when I see a virus that has that particular signature, I can infer that it passed through that location at that time.
So, if you look at the data from Wuhan, doctors were seeing success with contact case tracing and isolating all known contacts in January and February. What difference would it have made if our testing was up to par in late February?
The Massachusetts Department of Health was testing contacts. It just became overwhelming. The first one of the things that we found is that the first several introductions were identified by the surveillance system. The patients were quarantined. The contacts were monitored for symptoms, and we didn't see any descendants from those cases in the data set. And it suggests that the public health infrastructure can be effective. But for those first three cases, there were hundreds of individuals who were being closely monitored. And so what happened as the number of cases increased beyond dozens, beyond hundreds, the public health infrastructure simply became overwhelmed. And so, yes, I think it's always better, more testing, more surveillance, but there's just something fundamental about the epidemic process. When a virus moves this quickly, it is near impossible to have containment from a public health standpoint unless you are extremely aggressive, extremely early, and clearly that wasn't possible in this case.
239 scientists from 32 countries, in an open letter to the World Health Organization, outlined the evidence that smaller airborne particles can infect patients and asked the WHO to revise its recommendations. Clearly, no conclusive proof, and there are alternative explanations for outbreaks, such as the choir in Washington state, in which close proximity and loud singing could explain the outbreak with conventional large droplets. However, with these super spreader events, does that seem to push the argument one way or the other in terms of droplets versus airborne spread?
It's something that's been at the forefront of our minds. I think we don't have the data in this study one way or the other to explain the mode of transmission, but the more we see of these events, the more we're really left scratching our head with each of them. How did so much transmission occur if transmission requires people to be within 6 feet and coughing droplets onto other people? And I think the more events we see like this, along with other information that's accruing, the more it's clear that there's more to spread than close contact and large respiratory droplets transmitted through coughing and sneezing. So I think the evidence for airborne transmission is emerging. The epidemiological evidence is compelling. There's now some virological evidence as well, live virus isolated from small particles suspended in the air. So this is a growing concern. What is clear is that it is highly likely to be possible. What is not clear is how common, what proportion of transmission is due to these routes.
Based on this super spreader event in Boston and many others, what advice would you give?
We really need to be careful about any sort of large gatherings, uh, vigilance when it comes to masking and physical distancing. Something that's not in our study, but it clearly is a theme that's emerging, is that when people are indoors, particularly with alcohol involved, that is a set of ideal conditions for spread.
This study illustrates how a single introduction had an outsized effect on subsequent transmission because it was unfortunately amplified by superspreading in a highly mobile population very early in the outbreak before many precautions were put in place and when its effects would be further amplified by exponential growth. This study provides direct evidence that superspreading events may profoundly alter the course of an epidemic and implies that prevention, detection, and mitigation of such events should be a priority for public health efforts.